Bismillahirrahmanirrahim. Assalamu alaikum everyone. Today we will be talking about the dental implants. Now, dental implants basically come under the subject of implantology. This is a very vast and complex subject. In fact, it's a separate subject altogether. However, I will be just giving you a brief overview and discussing about the important points or the information that is required at the undergrad level, especially the preclinical level. So let's move on to the learning objectives. Moving on to the learning objectives, you should be able to define and list the components of dental implants, know the indication and contraindication of dental implants, which means that you should know who is the ideal candidate for dental implants, explain the available materials and surface coatings of implants, and differentiate between two very important terms that basically determine the success of an implant: osteointegration and biointegration. So, firstly, what are dental implants? So, they are the fixtures or prostheses that serve as replacement for roots of missing tooth or teeth and may be placed surgically in the maxilla or and the mandible. So, the principle of placement is based on attachment or bonding with bone over time, and they serve as an anchor for dental prosthesis. So, basically, because they are replacing the roots, and what is the function of the root? To basically provide anchorage or support within the jaw. So this is basically what the implant will be doing. They are more conservative than the conventional prosthesis option, as they conserve the natural tooth structure by eliminating need for adjacent tooth reduction, which we carry out when we are doing our conventional prosthetic work. For example, crown and bridge, we have to carry out tooth reduction or tooth cutting of the adjacent tooth, and along with that, they support and maintain the healthy bone in the region by basically preventing bone loss and resorption. So now the question is, why implants? There are a lot of reasons that why implants have become popular over time, and they are basically slowly replacing the conventional treatment modalities. So basically, to overcome the hassle of removable prosthesis, for bone health maintenance of the width and the height, for improved stability and occlusion, for aesthetically better tooth positioning, and for the better retention and natural feel. Let's look at the parts of the dental implants. Again, this is very basic knowledge. So you have the metallic or the ceramic crown, which is basically the artificial tooth replacement. Then the central part is the abutment. So basically, this is onto which the single crown or bridge attaches to, and then you have the implant itself. If we look at it in more detail, so this is basically the superstructure, the artificial tooth, then the abutment, and then the which is also the connection between the tooth and the implant. Implant has also been called a fixture or the root of a tooth, and this basically goes into the jawbone where it is surgically placed and allowed given time to heal and bond directly to the bone, and after the whole healing process the artificial tooth is placed on top. So who is the ideal candidate for a dental implant? So basically that person that possesses good general and oral health. Good general health means that he or she should be free from any kind of systemic or debilitating disease. And oral health means that you should have healthy gum tissues, free of periodontal disease, should have good oral hygiene, and and definitely should be affording, because dental implants are an expensive procedure. So again, that means that a thorough and good history and examination is mandatory before selecting or shortlisting your candidate for dental implants. Now, what are the contraindications? So there are various contraindications to dental implants, but however, we'll just look at the basic ones. So the few anatomical considerations, like if there is not sufficient alveolar bone above the inferior alveolar canal, and you are unable to locate the inferior alveolar nerve, or the maxil or the mandibular foramen. So this is a major contraindication because any kind of surgical insult by your instrument may cause paresthesia or dysesthesia of the gums, lips, and chin. So you should have good knowledge about the anatomy of the vasculature and the nerve supply of the concerned area. Then uncontrolled type 2 diabetes, as you know that diabetics have poor healing. So and that is because of the poor peripheral blood circulation, and good healing and a good blood supply or circulation is very important for a successful implant. Anatomic considerations regarding the bone, which is the volume and height of the bone available. All these things you can determine from good radiographs or x-rays. Implants are contraindicated with patients with certain drug history, like those who take intravenous bisphonates, so that are taken for certain forms of breast cancer, and they also cause osteoporosis, so this also can lead to delayed healing. Similarly, there are various other drugs that in which case it is contraindicated for such patients to actually go for implants. So again, a proper drug history, a proper medical history is necessary before proceeding with implant therapy. Then some parafunctional habits like bruxism, tooth clenching, or grinding. So this reduces the prognosis for the treatment and the overall success because forces during bruxism are detrimental to implants while the bone is healing. So now post-operatively, that is after the implant has been placed, there are some contraindications that means that we should take rapid action. So these include excessive or severe pain that lasts more than 3 days, excessive bleeding, constant numbness of the gingiva, lip, and chin even after the anesthesia wears off. So these are all the warning signs which require that we reevaluate our treatment and look into it deeper that what went wrong. Now, let's move on to the dental implant materials or the available options for dental implants. So, we can classify them into two groups, metals and ceramics. The metal options are commercially pure titanium and an alloy of titanium, which is Ti6Al4V. We studied both of these in the previous lectures, and then cobalt based alloys. Now, the other group is the ceramics, which are non-metallic. So they include the inert ceramics and bioactive ceramics. The inert ceramics are alumina, carbon, and zirconia, whereas the bioactive ceramics, as the name suggests, bioactive, basically they bring about a reaction at the bone and implant surface interface, and they cause bone deposition over there. So these are the bioactive glasses in glass ceramics and the calcium phosphates. A very important term, osteointegration, which is basically the fundamental of implant success and implant to bone bonding. It is defined as the direct structural and functional contact between the surface of implant and living tissue with the absence of fibrous tissue. As you all know, normal or physiological wound healing, basically, it is basically it involves the formation of a fibrous tissue, but in case of osteointegration, the interface we achieve between the bone and the implant is free of any kind of fibrous tissue or collagen, and it is a direct structural and functional contact between surface of the implant and the bone. As you can see from the picture, there is no fibrous tissue in between. So what happens in short, osteoblasts are laid down immediately onto the implant surface, and hence a bone implant interface is formed, and this is called osseointegration. This is a very complex physiological procedure, and again, I won't go into the detail. At this stage, you just have to know the definition of osseointegration and the fact that this is the main mechanism by which the bone and the implant are basically bonding together, and it is found in commercially pure titanium and titanium alloys, bioactive glasses and glass ceramics, and calcium phosphate. So basically this contributes to another quality of titanium, As I mentioned in the earlier lectures, that titanium is a very upcoming and popular material because it is highly biocompatible. And another feature is the fact that it can osseointegrate with the bone. And this is, in fact, the only metal that can actually osseointegrate with the bone. So osseointegration depends on a variety of factors like the quality of surrounding bone, the implant design, the surface morphology of implant, the implant material you are using that determines the degree of bone response over there, and then the surgical technique employed. So like I said, this is not a very simple procedure. This is a very complex procedure, a totally separate subject of implantology, and which is beyond the scope of just one lecture. So, but I have tried my best to actually give an overview of the whole procedure and the whole idea of what implants are. Now, just like osseointegration, there is another term called biointegration. So, osseointegration, we defined it as the structural and functional union between implant surface and bone, or the occurrence of extremely close proximity between a titanium alloy and supporting bone with no intervening fibrous tissue or collagen. And this occurs only in titanium and titanium alloys. If you can see from the picture of the implant bone interface, there is a space between both. So this occurs in osseointegration, whereas if you look at biointegration, which is the occurrence of continuity of ceramic implant to bone without space. So the main difference is the fact that in biointegration there is no space, whereas in osseointegration there is space, however, no fibrous tissue or collagen. And the second main difference is the fact that biointegration only occurs in the ceramic implant material, whereas osseointegration occurs in titanium alloys. So this is a major difference. Difference is that basically osseointegration, the bone and implant approximate to each other, but approximation is less than 100 angstrom. So angstrom is basically the unit which is 10 raised to the power minus 10 of a meter. So the space that we mentioned is present is less than 100 angstrom, and again no fibrous tissue, and only takes place in titanium and its alloys. Whereas in biointegration there is no space, the implant and bone are continuous and fused to each other, and it occurs only in ceramic and ceramic coated metals. By ceramic we mean calcium and tricalcium phosphates, hydroxyapatite, and bioglass. So these are the major differences between osteointegration and biointegration, and are very important. You should be able to appreciate the difference between both of them. Now, for comparison purposes, let's look at how a natural tooth attaches to bone and how an implant attaches to bone. As you all are familiar with the anatomy of a tooth and its supporting structures, you know that a tooth is basically held or supported within the gum or the alveolar socket by means of fibers, pedial fibers that hold the tooth to the bone or the gum to the tooth. And however, in case of an implant, because the tooth has been missing, there are no pedial fibers, no attaching fibers. So the basically the implant attaches directly to the bone by osteointegration, and that is a kind of replacement of the pedial fibers, and that is how basically it anchors or supports the tooth within the bone. Now let's move on to the dental implant materials or the available options for dental implants. So we can classify them into two groups: metals and ceramics. The metal options are commercially pure titanium and an alloy of titanium, which is Ti6Al4V. We studied both of these in the previous lectures, and then cobalt based alloys. Now, the other group is the ceramics, which are non-metallic. So they include the inert ceramics and bioactive ceramics. The inert ceramics are alumina, carbon, and zirconia, whereas the bioactive ceramics, as the name suggests, bioactive, basically they bring about a reaction at the bone and implant surface interface, and they cause bone deposition over there. So these are the bioactive glasses in glass ceramics and the calcium phosphates. Now let's talk about implant failure. Failure can occur basically if the implant does not osseointegrate properly with the bone or vice versa. And when is it considered to be a failure? If it is lost or if it is mobile, and if it shows a bone loss of greater than 1 millimeter in the first year and then 0.2 millimeter the following years after that first year. So these are basically the reasons, or these are basically how you determine that your implant has failed. And the important point is that implants do not have dental caries, because obviously they are not natural Basically they are artificial, they are composed of an artificial material, but they do develop a condition called peri-implantitis. Now peri-implantitis is basically an inflammatory condition of mucosa or the bone around the implant, and this results in subsequent bone loss and definitely ultimate loss of the implant. So the underlying reasons of peri-implantitis are usually a chronic infection, and it is seen more in heavy smokers, patients with diabetes, or who are immunocompromised, and definitely patients with poor oral hygiene, who do not carry out proper brushing and do not maintain their oral hygiene, and there are heavy calculus deposits around the implant. This can definitely cause to inflammation of the surrounding area, leading to peri-implantitis. So basically, this is peri-implantitis is also a reason of implant failure. Now let's talk about the classification of dental implants. So they can be classified according to the design, and there are three basic designs, and they're known as endosteal, subperiosteal, and transosteal. So let's look at the endosteal implants first. Endosteal are further divided into the ramus frame type, the root form, and the blade form. Root form are the most commonly used and the most popular implants. And so, what is an endosteus implant? It basically is placed in the alveolar bone or the basal bone of either the mandible or the maxilla, and it projects through the oral mucosa covering the edentulous ridge. And it transects only one cortical plate. So as you can see from the picture, there are three types: the blade form, the ramus form, and the root form. And they may be cylindrical or of the screw type. The further different types of endosseous implants. Then the subperiosteal implants, they are placed directly under periosteum overlying the bony cortex, and basically they're composed of a metal framework that lies on top of the jawbone. So basically, it's a very extensive implant that transects basically the top of the jawbone, and it lies above the bony cortex. Then the transosteal implant. This is only placed in the mandible. It's called the transmandibular implant or staple bone implant. So as you can see from the picture, it penetrates both the cortical plates, and it is quite deep, and this can be said as a combination of both endosseous and subperiosteal implants. And basically, it is composed of metal plates which are joined together. So again, the design of the implant depends upon your on the condition of basically the clinical condition, the requirement, and there are a lot of other factors that you basically look at before deciding on what kind of implant you have to give to the patient. If we look at the classification according to composition, as you know, there are of two types: metallic and non-metallic. So the metal that may be used for implants are titanium and titanium alloys, cobalt, chromium, molybdenum, which is also known commercially as vitalium, austenitic steel or the surgical steel, and then precious gold metals like gold, platinum, and palladium. So all of these metals have been used previously to make dental implants, but however, the first two, titanium and titanium alloys, are the only basically implants that have been successful so far, and they fulfill all the requirements of ideal implants. About titanium, we've discussed the properties many times, but with reference to implants, it's seen that as mentioned before, it is one of the most biocompatible material due to its excellent corrosion resistance. The corrosion resistance is due to the formation of a biologically inert oxide layer that forms basically whenever titanium is exposed to air, and this oxide layer is protective or passivating in nature, and it is most stable and mostly formed on the titanium surface. It is self-healing. That means if it is scratched or abraded, it repassivates immediately. Properties include the mechanical strength. It has good yield strength, tensile strength, and fatigue strength. Modulus of elasticity is 110 gigapascal, and it is half of other alloys and 5 times greater than the bone. So this is an advantage because it helps in the uniform stress distribution. It has good strength, but it is less than the titanium alloy. It is ductile, so it can be shaped into desired any kind of desired shapes for implant by machining. And the best part is that it has low density, it is highly lightweight, so that it makes it very comfortable for the patient. And the other property is that it can osteointegrate or grow directly within the bone. In spite of excellent corrosion resistance, there have been studies that reported that in trace amounts, peri-implant accumulation of titanium can take place in many organs like the lung, liver, and spleen, and it can result in metallosis. However, this is very uncommon and unlikely to occur. So it can be said that it is basically very bio. The titanium alloys, the titanium alloys commonly used for dental implants is Ti6A 6Al4V. The Al is aluminium 6% and the V is 4% vanadium. Aluminium is the alpha stabilizer, vanadium is the beta stabilizer. The aluminium contributes to the strength and the vanadium to the corrosion resistance. So together these two alloys, they further improve the properties of titanium. It has excellent corrosion resistance, again due to the presence of titanium that forms an oxide layer. Modulus of elasticity is also 5 times that of bone, so more uniform distribution of stress. Strength of titanium is greater than pure titanium and 6 times that of bone. So this is an advantage because you can use thinner sections. You don't have to make bulky implants. You can make thinner sections because its strength is almost 6 times that of bone. Ductility is sufficient, and it also shows osteointegration because of titanium, and uses basically used as an implant material due to the properties we discussed, which include biocompatibility, osteointegration, its good strength, and the fact that it has a high modulus of elasticity. Now, the cobalt, chromium, molybdenum alloy, which is commercially also known as Vitalium, it is composed of 63% cobalt, 30% chromium, which provides the corrosion resistance, and 5% molybdenum, which contributes to the strength. Now, the properties, as you know, it has very good mechanical strength and hardness, has good corrosion resistance due to chromium, however has low ductility, and compared to titanium it does not osteointegrate to the bone. However, there is direct apposition of bone to implant, and that with interspersed fibrous tissues. So this is a drawback of cobalt chromium, that it does not osteointegrate unlike titanium. Uses are limited to the fabrication of custom designs for usually subperiosteal frames only, due to the ease of castability and its low cost. Now let's move to the non-metallic implant materials, which include ceramics and carbon. So there are a variety of ceramics and carbon like aluminum oxide, sapphire, zirconium oxide, titania. Then the calcium phosphate ceramics. A lot of research has been done on these materials, and they include hydroxyapatite and tricalcium phosphates. As you all know, hydroxyapatite is basically the main inorganic component of bone and tooth. Then glass ceramics and vitreous carbon and carbon. Now, calcium phosphate cements, these are known as bioactive ceramics. So, bioactive means that they basically bring about a reaction at the site. And what is the reaction? Basically, they cause biointegration, they cause deposition of bone, and they possess a kind of biological activity, and that is why they are able to initiate or stimulate a response in the tissues. They mainly consist of hydroxyapatite and tricalcium phosphate. Properties are that they have excellent biocompatibility because their composition is similar to natural bone, and it can directly biointegrate or form a chemical bond with the surrounding bone tissue because it contains calcium and phosphate, and that is able to form direct bond with the with the bone. It has excellent biocompatibility, no known cases of local or systemic toxicity, and there is no alteration in the natural mineralization process of bone. It is just like normal bone deposition and bone healing. However, the limitations are that compared to titanium and other metals, it has poor mechanical properties like tensile and shear strength, lowers fatigue strength, and it is brittle and it has low ductility. Then we have the polymers and composites. Polymers, a lot of polymers have been tried, like polymethyl methacrylate, polytetrafluoroethylene. They have their own drawbacks. Then composites, we won't go into the detail because they're not used anymore. You just have to know for, you can say, general knowledge purpose that these materials have also been used. So, what are the requirements of dental implants? Ideally, a dental implant should have a biocompatibility and biofunctionality, and then only can it be termed a successful dental implant. Then, other factors are the biology, the wound healing, repair, modeling, remodeling, the mechanics, which include all the mechanical properties, the material processing, the shape, the design, the structure, the surface, how well it bonds to the bone, corrosion, iron release, wear, chemical factors like corrosion, iron release, environment, again, corrosion, iron release, wear. So, all of these properties together contribute to the optimal dental implant. Now, let's just look at the properties very briefly. You all are familiar with these properties. So, modulus of elasticity, or basically the stiffness, is the change in dimension with respect to stress. And ideally, a biomaterial with stiffness comparable to bone should be selected. And that is the case with titanium, that it has almost 5 times the stiffness of bone. And this ensures uniform distribution of stress at the implant bone interface. And advantage of the titanium. The tensile, compressive, and the shear strength basically should be high to prevent fracture and improve the functional stability. Strength and fatigue strength are also important because fatigue. Why? Because repeated loading, cyclic loading is taking place within the oral cavity. So the materials implant should have high fatigue strength and yield strength to prevent brittle fracture under the cyclic. Ductility, it should be high so that it doesn't fracture, and we can make the desired shapes and designs of the implant. Electrical and thermal conductivity should be minimum to prevent expansion, contraction, and oral galvanism. Biocompatibility, it should be biocompatible, however should not be totally inert. If it is bioactive, that is an added advantage, and it should be able to perform with an appropriate biological response in a specific application. um, If we talk about corrosion, there are various kinds of corrosions. We've discussed them previously. Corrosion should not be present in the implant, and if it doesn't, and it won't corrode because obviously we are using biocompatible materials like titanium, and the passivating oxide layer contributes to this corrosion. Now let's talk about the surface characterization of implants. So basically, that can make the implant more receptive to host tissue and improve the overall clinical performances. So we can carry out certain procedures or treatments on the surface of the implant to make it more receptive and to improve the properties. So we can carry out passivation. So this is the enhancement and stabilization of the oxide layer, and this in turn contributes to the corrosion resistance. And how is it done? By immersion in 40% nitric acid. This is only used for cobalt chromium implants. In acid etching, the surface can be treated with nitric or hydrofluoric acid. Again, this also makes the surface more receptive and improves the clinical performance. And then sandblasting, as you know, is basically a procedure by which we get a roughened surface texture. Now the roughened surface texture of implant increases the overall surface area. The surface area is increased, so there is better bonding to the bone, and it increases the attachment strength at the bone implant interface. The other procedure is surface coating. Now, this is a very popular procedure that has been carried out on implants nowadays. So, what is done is that the implant surface is covered with porous coatings, and this has shown to increase the surface area and roughness, which again contributes to better bonding, attachment, or integration at the bone implant interface. It has increased the biocompatibility, and there are various coating techniques that exist. However, we won't go into the detail. You just have to know that basically what we do is that we coat the implant, the titanium or metal implant, with either hydroxyapatite or other calcium phosphates, and this is done by plasma spraying. So this is a procedure by which we basically coat the implant with ceramics, and this increases its properties like the integration and the biocompatibility. This is just done to basically improve the properties of the implant. So at this stage, this is all you are required to know about implants, and I hope that it is clear. And thank you again for your time.